Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to yet another primary snippet. So this time we are going to dive into some of the pharmacology questions. So first question is compare and contrast the pharmacology of furosemide and acetazolamide.
So I think this, for a written answer, works best in table format. So you can see in the show notes, there'll be access to a table, but I'll go through some of the main points. With any pharmacology question, dividing it into the pharmaceutics, pharmacokinetics, pharmacodynamics is a pretty simple way to start and ensure that you don't miss any significant aspects. So in terms of the pharmaceutics, furosemide is a loop diuretic, whereas acetazolamide is a carbonic anhydrase inhibitor. And they come in formulations, both tablets and injections. So furosemide has tablets of various strengths, 20 and 40, and acetazolamide is just available as a 250 milligram. And they also have oral solutions for furosemide, but not for acetazolamide, and injection forms, which you can see the formulations within the table. From a pharmacokinetic point of view, I usually divide it into administration, absorption, distribution, metabolism, and elimination. So from an administration point of view, they both can be orally or intravenously administered, but furosemide can also be given IM, and its IV doses should be given no faster than 4 milligrams a minute, as it's thought that fast administration can result in ototoxicity. In terms of the bioavailability, furosemide has less bioavailability. It's 60 to 69% in healthy patients, but this reduces to just over 40% in patients with end-stage renal failure, whereas acetazolamide has a good bioavailability of 90%. The onset of action, furosemide is 30 to 60 minutes. With acetazolamide, it's 1 to 2 hours, but that reduces to 2 minutes after IV, and same with furosemide, just 5 minutes after IV administration. In terms of the distribution, they're both pretty similar. They're highly protein bound, over 90%. With furosemide, it's mainly to albumin, whereas acetazolamide is tightly bound to carbonic anhydrase and accumulates in tissues containing this enzyme, so especially things like red blood cells and the renal cortex. From a metabolism point of view, they both have actual very minimal metabolism. So furosemide has minimal hepatic and renal metabolism, and the main metabolite is furosemide glucuronide, whereas acetazolamide undergoes no metabolism. And the elimination, their half-life is about 2 hours in furosemide patients with normal renal function, which increases in patients with renal or hepatic failure. And for acetazolamide, it's 4 to 9 hours. Furosemide, 80% of an IV or IM dose is excreted in the urine within 24 hours by both glomerular filtration and proximal tubular secretion. And acetazolamide is excreted unchanged by tubular secretion in the urine, and that's enhanced in alkaline urine. From a pharmacodynamics point of view, so furosemide affects the thick ascending limb of the loop of Henle, whereas acetazolamide affects the proximal tubule. And the mechanism of action for furosemide is it blocks the sodium potassium 2 chloride transporter in the loop of Henle, which reduces the absorption of these ions. And this thus increases the amount of solute delivered to the distal nephron, which increases water excretion and also disrupts the countercurrent multiplier system by decreasing the reabsorption of these ions into the medullary interstitium due to a decreased osmotic gradient between the duct and the inner medulla. And if you need a refresher on the countercurrent mechanism, listen to our episode 2 weeks back, which we delved into that. From an acetazolamide mechanism of action, it acts on the proximal tubule by inhibiting carbonic anhydrase, and this blocks the conversion of carbonic acid into CO2 and water in the tubular lumen, and its conversion back into carbonic acid in the proximal tubular cells. In a normal situation, the carbon dioxide and water will diffuse into the proximal tubule cells and be converted back into carbonic acid by carbonic anhydrase. And then the hydrogen ions can then be exchanged with sodium from the tubular lumen. Acetazolamide therefore decreases sodium and bicarbonate reabsorption. When we think about the indications, they're obviously both diuretics, but furosemide we use generally for any edematous states such as CCF, liver cirrhosis, renal disease, and it also can be used in hypertension. Acetazolamide is not as effective a diuretic, but we can use it for metabolic alkalosis. We use it with other diuretics rather than as a sole diuretic usually. Other indications include the prevention of acute mountain sickness and the treatment of high altitude cerebral edema, and elevated intraocular pressure associated with acute angle closure glaucoma, idiopathic intracranial hypertension, and chronic open-angle glaucoma. When we think about some of the contraindications and precautions, obviously allergies for any drug, but some interesting ones to think about is for furosemide is treatment with other ototoxic treatment with other ototoxic medication, prostatic obstruction, as it can precipitate urinary retention. And for acetazolamide, if they've got severe renal failure with a GFR of less than 10 mils a minute, severe hepatic impairment or hepatic failure, as it decreases ammonia clearance and can precipitate hepatic encephalopathy, and any very hyponatremic or I've got a significant hyperchloremic acidosis. Both drugs in pregnancy, you need to use some caution. So for furosemide, it's a category C in pregnancy. It could cause electrolyte disturbances in neonates and thrombocytopenia. And for acetazolamide, it's a category B3, as it's shown to be teratogenic in animals at very high doses. That being said, the doses used in animals were much higher than we use in a human population. And there's no well-controlled human studies, but it's generally avoided, especially in the first trimester. From an adverse effect point of view, furosemide, as we've said, can cause ototoxicity, hypotension, anorexia, pancreatitis, increased triglycerides and cholesterol, and some hematological effects such as aplastic anemia. Whereas acetazolamide can cause some of these GI effects like nausea, vomiting. It can also cause aplastic anemia and hypersensitivity reactions. And then the important thing to think about is also the electrolyte effects. So for furosemide, the classic electrolyte effects are hypernatremia, whereas for acetazolamide, it's hyponatremia. They can both cause hypokalemia. Furosemide can cause a metabolic alkalosis, whereas acetazolamide can cause a metabolic acidosis. And furosemide can also cause hypophosphatemia, hypomagnesemia, and hyperuricemia. And the final thing to think about is significant drug interactions. So for furosemide, anything that can also has a risk of ototoxicity, such as aminoglycosides, you have to use it with caution when you're using furosemide. Chloral hydrate, which you might use in pediatric patients, it can cause flushing, hypertension, and tachycardia. With lithium, it decreases the excretion of lithium, whereas lithium for acetazolamide, it increases lithium excretion, and it could also increase phenytoin levels and accelerate osteomalacia in patients who are having phenytoin. And there's some more significant drug interactions that you can check in the show notes.
Thank you. So again, this question was asked for VIVA in recent settings, and often the VIVA might start as classified diuretics. An examiner will get you to start with classifying different diuretics and then dive into one of the diuretics and then ask more in-depth and check your more in-depth knowledge about particular diuretics. So carbonic dehydrogenase inhibitor like acetazolamide, it's often not well-read drug. So I think thanks, Maddie, for covering that. That's really useful. So that's the end of our today's snippet. We'll be back with another snippet in week's time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.